What is going on, everyone? Welcome back to my channel and our kinesiology lecture series in basic biomechanics. If you've watched all the lectures and been following along, thank you. It's a lot of content, so props to you for getting through it. If this is your first lecture in this series, make sure you go back and check out all the other material. We covered the upper extremity, all the shoulder, elbow, wrist, and hand, other introductory material related to biomechanics, and today we're going to talk about the ankle and foot. And then really our last lecture is the next one, which is on the human gait cycle or the walking cycle. So if you want to learn more about the gait cycle, come back for that one. So anyway, we will, again, this is our last one in the lower body. We did hip and knee, and now we'll look at the ankle and foot, a little bit on structure and function, and then some of the relevant pathologies that are out there. So, all right, let's jump into it. So when we're looking at the human ankle and foot, just basic functions, one really important one is going to be to provide a stable base while conforming to uneven surfaces. So this is one I actually talk about quite a bit with people because there's a lot of there's this idea out there with a lot of people that that when your foot pronates that's something bad. And pronation is actually the way that our foot absorbs shock and part of how it conforms to uneven surfaces. So I try to get people out of this mindset. You know, sometimes we kind of demonize certain movements and certain postural positions, and pronation in the foot is one of those. So your foot, you want it to be able to pronate and supinate and kind of move through those movements, because that's how we, if you think about walking across, some rocks, maybe you're hiking or something like that, your foot has to change shapes and conform to those surfaces so that you can kind of keep moving forward. So it's a major function, but it's also, the foot has all these ligaments we'll look at and a number of muscles, 5 layers of muscles in the sole of your foot, and then these bigger muscles that come from the shin that will help us move our ankle and foot and maintain the shapes of the arch. We'll look at some different arches in the foot. So a really complex structure. I mean, the foot is sort of like the hand in that way. It's a really complex area. There are some clinicians, whether you're looking at surgeons or physical therapists, who only treat the foot. So it's a highly specialized area. Some other, so shock absorption through that foot flexibility, again, especially pronation. Most of us have kind of a little bit of a longitudinal arch where our arch sort of sits up a little bit, like our hand. If you look at the hand, it sort of has this arch when it's resting. The foot has the same thing. And so the foot sits somewhere in between, kind of being fully supinated and fully pronated for most people. And then when they hit the ground, if you watch people walk, they'll pronate, and that's how they absorb shock. And we'll talk about that more in the human gait cycle. You can watch people as they walk away from you. If they're barefoot, you can see their foot pronate and absorb shock and resupinate again, so it will move through those different movements. The foot helps to transmit rotational forces into forward progression. The foot obviously is really important for just walking, and so again, it will go from, the foot is interesting that it will be solid at times when we're walking, and then it will become flexible and absorb force, and then it will become solid again so we can push off. So it's everything that happens in the foot just with something simple like walking is really pretty cool. And then again, that rigid lever for propulsion. So the way you can think about it, most people have heard of pronation. The opposite is supination. Pronation is when your foot's flexible and conforming to surfaces. Supination is when it's rigid, and that's how we typically land when we're walking, and then when we push off. If you think about when you push off with running or walking, you want a real rigid foot so that force transfers in the ground and you can push off with more force. So we have both of those kind of opposing sides to the foot. Just looking at some anatomy of the ankle, we'll start up a little more proximal and work down into the foot. So the ankle is also called the talocrural joint. It's basically where our tibia and fibula come down and form the mortise. And then that mortise is sort of like the roof of the ankle. It kind of sits like this. And then in there is the dome of a bone called the talus. So the talus is going to sit in there, and that's going to form our ankle joint. It's a hinge joint, and this might be surprising to people because you think about you can kind of spin your ankle in circles and do all these different movements, but really the ankle joint itself, the talocrural joint, only allows flexion, extension, or we call it plantar flexion and dorsiflexion. Those other movements, inversion, eversion, pronation, supination, those occur because of other joints lower down in the foot. So the ankle joint by itself is just a hinge joint. It's kind of like the elbow. It just allows flexion and extension, or again, plantar flexion and dorsiflexion. So we say this is 1 degree of freedom because it's just moving in that one plane, the sagittal plane of motion. It has, when you look at the articulations, again, from a proximal standpoint, as I said, we have the tibia and fibula, which form the mortise, or the roof of the joint. This is where people have high ankle sprains. I wrote a post on this the other day. High ankle sprains occur up towards this mortise, and then the distal end or bottom of the mortise is the dome of the talus bone, and that sits in that. And I've got a video here in a second so that'll help you visualize these. Ligaments, there's a bunch of ligaments in the ankle. I broke them down in terms of if they're on the medial side of the ankle, the inside of the ankle, or if they're on the outside or the lateral side. The medial side has this really big, strong, dense ligament called the deltoid ligament. Not very often do people tear this. Sometimes if they have one of those high ankle sprains and they are in a contact sport like football and they're tackled and their foot's stuck to the ground, it can tear the deltoid ligament. But in most cases, the typical ankle sprain is one where the person lands and it rolls in. You think about rolling your ankle, it rolls into inversion, and that damages these ligaments out here on the lateral side. And the one that is most often torn is this anterior talofibular, or we'll often call it just the ATFL. But those ligaments are on the outside of your ankle, and if you've ever sprained your ankle, you'd see a little pocket of swelling, in many cases just below that bone on the outside of your ankle, the lateral malleolus. So these ligaments are on that outside and attach the bones together. And again, the ones that will usually... Ankle sprain is the most common orthopedic injury, and these are the ligaments that are usually stretched or torn. Okay, just a quick image here to kind of help you orient yourself. So if you look up above, this main bone in the shin is our tibia. It's our main weight-bearing bone. The fibula is this little one on the outside. It's not a major weight-bearing bone. So, if people fracture it, sometimes they can actually be putting weight on their leg right away again because it's not a major weight-bearing bone. But those two together form this roof that sits on top of the talus right here. And then we've got the navicular bones. There's another, so I mentioned before, when we think about the ankle, it just does plantar flexion and dorsiflexion. That's coming from this joint. But then we have these other joints down here. We have the subtalar joint, we have the calcaneocuboid, we have the talonavicular joint. These other joints in the midfoot and the subtalar is part of the rear foot, those allow us to invert and evert, pronate and supinate. They allow that flexibility that occurs in the foot. So you may have heard of some of these other, bones down here. Right? Everybody's probably heard of the calcaneus. That's your heel bone. Your Achilles tendon attaches back here. Sometimes people get heel spurs on their calcaneus. The cuboid is this one, and the navicular is this other midfoot bone. These two are two of the bigger ones in the midfoot. And then we have these cuneiforms, our metatarsals, and then we get up here into the bones of the toes or the phalanges. So just a quick little anatomy review for you. So again, a lot of different joints that really help the foot conform to uneven surfaces. Okay, let's look at osteokinematics. So you remember osteokinematics are the big bone-on-bone movements, flexion, extension, abduction, adduction. So we'll look at these here in the ankle. If we look at dorsiflexion of the ankle, which is pulling your toes up towards your nose, if you look at sort of the normal range of motion in terms of what textbooks would say, they would say we should have about 20 degrees of dorsiflexion. This is really most often measured when the person is laying on their back and pushing the ankle up and then using a goniometer to measure. If you actually have someone stand on their leg and push their knee forward over their foot, they can get more range than this when body weight is on the joint and the knee is bent. So if your knee is straight, if your gastrocnemius, one of your calf muscles is tight, that can limit dorsiflexion due to this idea of passive insufficiency of the muscle. So if you want to know exactly what the joint can do, you want the knee to be bent. So that standing version where you push the knee forward is actually a better way to see the true range of motion in terms of dorsiflexion of the ankle. And then plantar flexion, we have more. If you think about pointing your foot, like a ballet dancer or something, you can point quite a bit farther than you can pull it up. So in terms of plantar flexion, the reference will commonly say 55 degrees of total excursion. And then again, just, there's different sources out there. So some sources you'll see dorsiflexion. If you actually look at people on average, don't tend to have this 20 degrees, especially if their knee is straight and you're testing in the typical clinical fashion. So some sources will say, oh, it's only about 4 degrees. A lot of people are limited in dorsiflexion. It's one of those areas that if you look on social media, a lot of us talk about dorsiflexion mobility and how to gain mobility here. So a lot of people who can't squat all the way down, it's because of the limitation ankle dorsiflexion. So it's one that's addressed a lot, and there's a lot of people that probably really are in this range, around 5 degrees of dorsiflexion. And then plantar flexion's often less, than what some of the sources will say. And again, this is, because of surrounding muscle attachments. Like I said, if your knee is straight, dorsiflexion will a lot of times be limited because of calf and Achilles tendon flexibility. So bending the knee and having the person put their body weight on it is a better gauge of their true joint mobility. When we get into the gait section, we'll talk about this more, but most gait research will say that we need about 10 degrees of dorsiflexion. This should, it isn't listed here, but 10 degrees of dorsiflexion to sort of walk normally in the gait cycle. That's sort of the average for most people. So again, we'll look at that more. And in gait, you would see, in gait, it's easier to achieve 10 degrees versus this 4 because, again, your body weight is on it. The Achilles tendon is so stiff that you almost need body weight to get the joint to move through greater excursions. So those are the osteokinematics for the ankle joint. Again, just really dorsiflexion and plantar flexion. The arthrokinematics here, these are the accessory movements. Again, can be a little confusing since we're kind of breezing through these pretty quickly compared to a normal class. But if you think about the ankle joint, you've got the roof, which is the concave structure. The tibia and the fibula come down and make a concave structure. And then the dome of the talus is convex. So you've got a proximal concave end and a distal convex end. So, what you want to kind of orient yourself, because again, the convex and the concave side of the joint are going to follow different mechanical patterns. So if you think about dorsiflexion and we think about which bone is moving, okay, so that's how you want to orient yourself. So here in this one, we're talking about the talus moving on the tibia and fibula, which would be like if you're just sitting here right now and your foot isn't on the ground, open chain, and you pull your toes up towards your nose. If you imagine that in an open chain scenario, if I'm just pulling my foot up, my foot's not on the ground, that is my talus bone primarily moving on my tibia and fibula. And since the talus is the convex end, we know that the convex bone, the roll and glide occur in opposite directions. So in this case, when we pull our foot up in a dorsiflexion, we would get anterior roll. The talus would roll anteriorly in the joint, and we don't want it to pop off the front side of the joint, so there has to be a posterior glide to keep it centered in the joint. Now on the flip side, if you were doing a squat, imagine you're going down, the eccentric portion, you're going down in a squat, your ankle is moving into dorsiflexion, but now your foot is fixed on the ground. So in that case, the talus is pretty much fixed like this, and the tibia and fibula are moving over, so they're the part moving on top of the talus. So in that case, the concave side of the joint is moving, and the concave bones have roll and glide in the same direction. So in this case, if I was standing like this, I went down in a squat, I would have anterior roll and glide. The tibia and fibula are both rolling and gliding anteriorly as I go into dorsiflexion in a closed chain fashion. So again, this stuff is the hardest part of these kinesiology courses on biomechanics. So if it's really difficult, don't worry about it right now. We'd spend a whole class period doing examples and going over this. So it's Kinematics is hard for people spatially to imagine. So just do your best with it. Plantar flexion is just going to be the opposite. So if we're looking at the talus, it's going to now have posterior roll and anterior glide. If I'm just sitting and pointing my foot, it's not on the ground, I'm just pointing it. And then on the flip side, if the tibia and fibula are moving on the talus, so in a closed chain type of situation, then I'm going to have posterior roll and glide. So they're literally just the opposite of dorsiflexion, depending on which bone you're talking about moving. Here's an image of this. So if we look at, these are open chain movements. See, the foot's not fixed to the ground. So the person's foot's mainly moving. So again, that means the talus is mainly getting moving, which is right here. This dome is the dome of the talus. Here's dorsiflexion. If we look at dorsiflexion, maybe this helps you kind of visualize it. As the toes come up towards the nose, we're going to get an anterior roll. So this arrow is trying to show it's rolling anteriorly towards the front of the body. And if it just kept rolling that way, the joint wouldn't be centered, the bone wouldn't be centered in the joint anymore, and it might come off the front side and damage structures up here. Maybe you get an impingement or something. So we have to have a posterior slide or a glide to keep the talus centered in the joint. Okay, and then on the flip side, plantar flexion. In this case, as we point our foot, we're going to have a posterior roll, just the opposite of dorsiflexion. Posterior roll and an anterior slide. Okay, so again, that's an open chain movement. Your foot's not fixed to the ground. The talus is moving on the tibia and fibula. And then I don't have an image of closed chain, but you know, you would imagine then that the foot's on the ground and the tibia and fibula are moving over the foot. Oh, so I take it back. Here's one. At least we have dorsiflexion closed chain. So here, this is what most people are probably going to see, right? If you're doing a squat or a lunge or something, your foot's on the ground and your tibia and fibula are tipping anteriorly to create dorsiflexion in your ankle. In this case, the mechanics aren't listed here, but again, this is the concave side of the structure. The bones are tipping anteriorly. And since it's the concave side of the joint, we know roll and glide occur in the same direction. So this is going to be anterior roll and glide of the proximal end of the joint, primarily the tibia, on the talus. Okay, so hopefully that makes some sense. If you get into a field where you're doing manual therapy on people, these convex concave rules were the foundation for mobilization. So for instance, if I had somebody with limited ankle dorsiflexion and I wanted to mobilize their joint to help them gain dorsiflexion range of motion, and I was going to mobilize their talus, the mobilization would be in the same direction as the glide of the joint. So look back here. If dorsiflexion is anterior roll and posterior slide of the talus, that means that my mobilization would be a posterior glide of the talus to help the person gain dorsiflexion. So I have a post on this, a video showing it on Instagram if you want to go back and see it. But these convex concave rules were really the foundation for manual therapy based joint mobilization. So if you go down that road, understanding these can be helpful in terms of knowing why you're mobilizing in a certain direction. Okay, here's just a little kinematics video. I think it's a cool one. Just to look at that, look how from this view, this sagittal view, how cool it is to see the talar dome there moving inside the mortise. So it really gives you an appreciation of this proximal end being more concave and the distal end being more convex, and maybe being able to see a little bit of that roll and glide. Roll and glide is tricky to see sometimes in a video because they're occurring at the same time, and that's how the joint stays centered. So if you look at that, the talus is pretty much staying centered in the ankle mortise, and that's because of roll and glide happening at the same time. If we didn't have those, then the bone might roll kind of out of the joint and put stress on peripheral structures like ligaments and tendons and the joint capsule. So they're just the mechanics that are occurring there. And then right down below here you can see the subtalar joint, the joint between the calcaneus and the talus, and then some of the other midfoot joints that we talked about before. So just kind of a cool little kinematics video of dorsiflexion and plantar flexion, the main the movements that occur in the talocrural joint. I already talked about foot anatomy a little bit, but let's just cover it briefly here again. So the foot's going to be broken up into the rear foot, midfoot, forefoot. Those are your main sections. The rear foot is at the back of the foot. It really just contains two bones, the talus, the bone, other half of the ankle joint, and then the calcaneus or our heel bone. Okay. And then the midfoot is going to have the navicular and cuboid. The navicular is on the medial side. Sometimes you can feel a little bump on the inside of your arch. That's a prominence on the navicular bone. And then we've got the cuboid. So we've got those kind of two big bones in the midfoot, and then these three cuneiforms. Okay, and then the forefoot is going to include all the metatarsals and the phalanges. So those are kind of your sections. You've got the forefoot right here, got your midfoot, and then you've got your rear foot. Okay, so that's how we kind of across the board break up the foot when we're assessing and treating patients with foot issues. So just a little anatomy review. Okay, let's talk about the subtalar joint. This is a really important joint. It's important in terms of allowing other movements in the foot and ankle, and again allowing us to conform to uneven surfaces. So the talus, the subtalar joint is really the talus, that other half of the ankle joint, and it's sitting on top of the calcaneus or the heel bone, right? It's right back here. It's kind of down underneath right here, underneath the talus. This is a top view, but it'd be down underneath there. And it has three separate contact points or articulations, so almost three separate mini joints, but it has a single joint axis that runs through it, which is going to influence how it moves. So again, subtalar joint's really important for dampening lower extremity rotations. It helps the foot conform to uneven surfaces. It's really where a lot of our pronation and supination is coming from. There's a couple other, some of the midfoot joints are going to contribute too, but this one's huge in terms of changing the shape of the foot and arch and allowing us to conform to different surfaces and relock the foot so we can push off and have this rigid lever for propulsion. There are a number of ligaments down here. The deltoid ligament again. There's the calcaneofibular, a cervical ligament. All these ligaments that are gonna again play a role in passive stability of the subtalar joint. So we've got some that are more associated with the talocrural joint, the upper ankle joint, and then again some ligaments that are part of the subtalar joint. I mean, almost any synovial joint in the body, right, is going to have ligaments around it to give passive stability, and there are muscles and tendons that will help us with active stability. So the osteokinematics of the subtalar joint, this is where we're going to start seeing pronation and supination. So pronation is referred to as the loose pack position, which if you maybe remember from a really early lecture, if you've been following around, loose pack is the position where the joint has minimal congruency. It's where the joint's going to have the most play in it. You know, it's going to be able to wiggle a little bit. It's not going to be so tight. And pronation is that position for the subtalar joint. So there's the least amount of contact between the bones, which means that the foot's going to be more flexible when it's in pronation, which again is why pronation is important. It allows us to absorb shock during the loading phase of gait. The foot pronates, we absorb force, the foot conforms to different surfaces, and that's the loose pack position. Supination, on the other hand, is the closed pack position. This is where the foot becomes sort of one solid, uniform, rigid piece, which allows us, we land that way at heel strike when we're walking, and then at toe off in the gait cycle, as we go to push off that foot, the foot will re-supinate because of subtalar joint movements, which will make the foot solid so that we can push off. I mean, imagine if you had a foot that was really floppy and flexible at push off, you wouldn't get any force to push off with. You couldn't push into the ground. So you need the foot to re-supinate and become tight after it's absorbed force and become flexible earlier in the gait cycle. Arches, arches are like the hand. We have these in the foot, and they're important in terms of passive stability. Again, they give shape to our foot, but they're going to be more like ligaments in a way where they're passive stabilizers. We can't voluntarily contract our arches. It's more of a dense connective tissue like a ligament. And we've got a longitudinal arch that runs sort of the length of the foot from the calcaneus to the metatarsal heads up towards the balls of the feet. And then the transverse arch runs across the tarsals and proximal metatarsals. So this is kind of back towards the rear foot and midfoot. It's going across the, well, really more midfoot, but tarsals and proximal metatarsals. And then, these arches, again, are kind of like ligaments, but they're a different classification. They're a different thing. If you think about like your plantar fascia, that's kind of a different structure. It's going to be more associated with the arches than deep underneath that, right down to the bones. Deeper in are going to be our different ligaments. We've got, maybe you've heard of the spring ligament. Spring ligament injuries are often a major problem for people in terms of foot function. Long and short plantar ligaments, again, the plantar fascia, all of these passive structures that give stability to our foot. And then, in terms of muscles that help support the arches, two of the really big players are tibialis posterior on the medial side. This tibialis posterior is huge in terms of lifting our arch. This is one that we do a lot in rehab. If people are having an arch that's slowly falling or they have arch-related pain, we'll often give them tibialis posterior activation and strengthening exercises. Peroneus longus on the lateral side, on the outside of the ankle, is sort of like an antagonist to tibialis posterior, so those two really kind of create almost like these stirrups that go around, come down the shin and onto the foot on the inside and outside and help to support the arch. And then, of course, there's a bunch of other muscles I'm not mentioning here that are in the sole of the foot, 5 layers of muscles. It's really pretty incredible if you ever get a chance to dissect the foot on someone. Once you cut the plantar fascia away, there's all these layers of muscle in our foot. And there are different exercises for training those deeper muscles in the foot, the intrinsics. So just looking a little bit, just a real simple diagram of the arches, and I mentioned the spring ligament. If then that's torn, it can be really, a lot of people have to have it surgically corrected because of the instability it creates in the foot. Our plantar fascia, if you think about plantar fasciitis, this often affects and irritates this structure. This diagram, we'll talk a little bit more about this on the next slide, but when your toes are flat, the arch will sit a little bit lower, because if you imagine these plantar, your plantar fascia, it's sort of a little more relaxed here because of how it connects up here towards the toes and then from the heel. When we lift our big toe into dorsiflexion, it actually pulls tension on the plantar fascia, and that causes our arch to lift higher. And this is really important in the gait cycle. It's something we call the windlass mechanism. And if you think about it, when you're walking, as you go to push off, the ground causes your big toe to go into dorsiflexion. And when that big toe goes into dorsiflexion, it pulls this plantar fascia tight. That pulls on the calcaneus and actually causes the foot to supinate and become rigid. So it's really pretty cool, all the biomechanics that go on in these different regions. But that's how our foot becomes a solid, rigid lever, is that when we go to push off, our big toe moves into dorsiflexion. That puts tension on the plantar fascia on the bottom of our foot. That pulls on the calcaneus, and that pull on the calcaneus causes supination of the foot, and then the foot becomes solid, and we can push off it. And all these things that happen without you thinking about them. So just another image of this here. There's a sesamoid bone. If you remember, sesamoid bones are bones that increase the mechanical advantage of different muscles. And so this muscle here, flexor hallucis longus, is a flexor of the big toe. So it's one of the flexors of the big toe. It runs on the bottom of the foot. And this sesamoid bone increases the strength, basically, of flexor hallucis longus. It's sort of like, our kneecap is a sesamoid bone. The pisiform bone, again, on our hand right here is a sesamoid bone. But when our big toe gets lifted here in a dorsiflexion, you can even see this. If you're just sitting here now and you lift your big toe, you can kind of see that your arch will lift a little bit. And that lifting of the arch is associated with supination of the foot, which locks the foot. So when the rear foot supinates, because again, that plantar fascia pulls on the calcaneus, and the calcaneus is part of the rear foot. So that tension causes as it pulls on the calcaneus, it moves the subtalar joint right here. It moves the subtalar joint and creates locking of the foot, and we call this the windlass effect. And it's really important when you go to push off when you're walking, because it locks the foot and allows us to push off with a rigid lever. Okay, muscular support, just real brief. I mean, there's a ton of muscles. I'm not going to cover all, and this is just a really quick glance at it. Statically, if you're just standing still, there's not a ton of muscle activity actually in your foot. Our foot is mainly stabilized by the plantar fascia and all of the surrounding ligaments. So when you're just sitting, standing still, not a ton of muscular activity. From a dynamic standpoint, you've got tibialis posterior I mentioned before at the top of the list here on the inside, peroneus longus on the outside. These other big ones, flexor digitorum longus flexes all of our smaller toes, and then flexor hallucis longus flexes the big toe. But there's a ton. I mean, there's a ton of muscles. This is just a few of sort of the big players that dynamically support our foot. But again, if you just go into Google and look up the muscles of the foot, there's a ton of them. Okay, just a quick look at pathology. So I'm going to break this down by different categories. One category is structural, and this can include things like Pes Planus and Pes Cavus. I haven't mentioned these terms, so they probably sound funny to you, but Pes Planus basically means an overpronation of the foot, and Pes Cavus is an overly supinated foot. Now again, if you have a flat foot, it doesn't necessarily mean that that's bad. There's a lot of people who are just born with flat feet and they grow up with them, your body adapts to it, it's not a big deal. And on the reverse side, there's people with really stiff, high arches. So those don't necessarily mean that you're going to have problems. But if you do have pain and you have, say, a flatter arch, especially if your arch, the people we worry more about are people that had a normal arch and then it sort of falls over time. That, because it's a new stress on the system, can be associated with pain. And with the person with a flatter arch, we might incorporate some foot strengthening exercises to help them learn to control their arch and lift it. The person who is a stiff, high arch, those would be people more, we might give mobility exercises to. We might mobilize their joints of their arch to try and kind of loosen it up and allow it to absorb shock better. Rearfoot, Varus, and Valgus are movements back with the subtalar joint. You'll see the calcaneus sort of sit in. It'll kind of, in rearfoot valgus, it'll kind of swing out, and the person will be more pronated. A person with rearfoot varus, their calcaneus will spin in, and they'll have a more supinated foot. I have some pictures here in a second to show this, but you might see if you're ever standing behind people and they're barefoot from the back, most people, their Achilles tendon is fairly vertical, but sometimes you'll see people where the Achilles tendon is swinging inside or out because of rearfoot varus or valgus. So again, it's something that's more of a structural change, and sometimes it's not an issue at all. Some cases it might be associated with pain, and we might work to kind of help them control it. From a functional standpoint, first ray hypomobility, this basically means stiffness in your big toe. This really can be an issue for people if they're dorsiflexion again. It's all about dorsiflexion in the ankle and foot. If your big toe loses dorsiflexion, it's supposed to have about 60 degrees when you're standing. If that becomes really stiff, it can be hard to, think about when you're walking, your big toe has to dorsiflex so you can push off. If you lose that range of motion, it can cause pain, it can interfere with your gait cycle. So there are ways the big toe, the joints there can be mobilized. There are stretches you can do to help stretch that joint out. Hallux abductus valgus is basically a bunion. So this is the technical term for when people have a bunion. So it's that inward angulation of the big toe. And bunions aren't just biomechanics. They have a genetic component to them. There are exercises you can do, behavior modifications. Try not to wear shoes that are too tight in the toe box. There are things you do. There's these little toe spacers out there you can get to try and help your big toe if you're starting to develop a bunion. And if it gets really bad and it's super painful, sometimes surgery is the best option. And then, the ones that, some of these aren't necessarily traumatic, but, muscle strains can be traumatic. We see people strain their calves. Tendon tears are a big one down here, right? Nobody wants to have an Achilles tendon tear. That's probably the big one we think about from traumas. And then, of course, ligament sprains. tons of ankle sprains. I mean, like I said, it's the most common orthopedic condition, especially inversion sprains where it tears the lateral ankle ligaments. So, and then we see lots of tendinopathy, which is not really traumatic. Most of the time, it's usually more of a repetitive kind of almost overuse pathology. But things like Achilles tendinopathy, we see a tendinopathy in things like tibialis posterior, tibialis anterior. Think about all the people who get shin splints. Sometimes in the peroneal muscles, we can see tendinopathy. Plantar fasciitis is now considered more of like a tendinopathy, almost a plantar fasciopathy. So, those are some of the big ones. And if you have questions about, exercises and ideas for these, again, I've covered all of them in previous social media posts. So just send me a message if you can't find something. I just want to end on a video showing a test that's commonly used to diagnose Achilles tendon tears. It's called the Thompson's test. And basically, if somebody's suspected to have torn their Achilles tendon, there's a simple test you can do where you squeeze their calf muscle. And normally when you squeeze the calf muscle, it causes the person's foot to point. It's sort of like if they were squeezing the muscle, but instead you're squeezing it with your hand. If the Achilles tendon is torn, the ankle won't move at all. So this is just an example. You'll see they're going to squeeze the person's uninjured leg first, and you'll see their ankle kind of move through plantar flexion. And then they'll squeeze the injured side, and you see the ankle won't move at all. So check this out. Oh, sorry, I forgot about these. Here's movements of the calcaneus. Remember I said most people, their Achilles tendon will be straight up and down. Here's calcaneal valgus, where the heel bone is kind of turned out and it causes the foot to pronate, especially on this side. You can see it sort of pushes the medial malleolus in and flattens the arch. That'd be more of a calcaneal valgus. This side's a little more vertical. And then here's a calcaneal varus on both sides where the heel bone turns in and it looks almost like almost looks like the person's going to roll their ankle and have an ankle sprain. But this is just structurally how they've developed. So, sometimes you hear of kids having really severe deformities like this where they actually have to break they have to dislocate the bone, the joints, maybe even fracture the bones and then reset it if it really interferes with function. Okay, and then here's and then how these things can contribute to, again, Pes Planus is overpronation, Pes Cavus is oversupination. So Pes Planus, if we had this calcaneal valgus position where the calcaneus points out, that can cause the ankle, the arch to collapse and contribute to more pronation. And then on the opposite side, a really supinated foot might have more of this calcaneal varus where it turns in and lifts the arch. So you can kind of look for that in people. A lot of times, it's a structural thing, so it's pretty hard to change on people. It's we really just kind of help. If they have pain, we help give them exercises and things to help build up the strength and capacity of their tissue, and hopefully that will help to alleviate their pain, because rehab isn't going to really change the shape of those bones or joints too much. So, okay, and the last thing here is this Achilles tear. So you see that moves the ankle, Thompson's test, and then on this side we see no movement of the ankle. So the Achilles is ruptured over there, and again, they would confirm this with MRI, but you see how that on this injured side, it doesn't move the foot. But on the healthy side, it causes plantar flexion. So this is a test that's done a lot by orthopedic surgeons and physical therapists to, if an Achilles tear is suspected, this is a quick, easy one that can be done. So, all right, everybody, thanks for coming back here again and watching these. This is wraps up our last joint lecture, and then we'll just have one more on the gait cycle, and that will pretty much be the end of this biomechanics series. So I hope you're enjoying it. I hope you're getting something useful and helpful out of it. Maybe you can apply it to whatever kind of clients or patients you work with. So, and maybe it's just maybe it's just entertaining. I don't know. So, all right, I will talk to you guys, or I'll see you guys all next time. Bye.